you, everybody at Nelson Mullins. And also, what a great reminder that it is Veterans Day. So thank you for reminding us of that. And thank you to everybody who has served and is currently serving. I am so excited to be here today. And I'm going to be talking to you a little bit about value-based care and value-based payment. But really, my job here is just to launch into and give you the best overview of what is value-based care and payment. What is this movement? If you're newer to the movement, you may not be completely familiar with what's going on in the space, but what I would like to start with is just a little bit of an overview. All right, so I'm going to start with the state of value-based care. Really just bringing you guys up to speed of what's happening in the ecosystem so that as you listen to the panels later today, you will be able to place this all in context. As Ed said, I'm Juliette Price. I'm the Chief Solutions Officer at HSG Global. As Ed mentioned, we're a firm that focuses specifically on the move to value-based care here in the United States and also across the ocean over in Europe as well. So what is value-based care? If you're newer to this content, newer to this ecosystem, you may be hearing a lot of different words being thrown around. We talk about value-based care, we talk about alternative payment models, value-based payment, value-based contracting. We haven't done the best job of keeping the lingo very clear. So I just want to say all of these are going to be used interchangeably. And as you hear the panels later today, you may hear different people use some of these different monikers to talk about the move to value. In general, what we're talking about is a move away from the fee-for-service payment and clinical models of today. That's the most important thing. The big concept here is that if we simply pay for more services, we're never going to get the results that we want. And I'll show you some of the outcomes, a chart that some of you may be completely familiar with. But really what we're changing here is if we change the way we pay for healthcare, we're going to get different results. So moving away from that left-hand side of the screen where you see payment for volume and really moving to payment for value. So why is this so important? When you look at all across the globe, different countries, different health systems, different manners of paying and providing healthcare. Unfortunately, the U.S. stands out and not in a positive way. We see the highest per capita spending, and unfortunately, we don't see the best outcomes. You can look at lots of different measures to see where that outcomes graph does not give us the results that we want. Obviously, this one is avoidable death, but you can look at pretty much any clinical measure and we are not top of the table. And so really what this leads us to is to a pretty big conclusion, right? Is that we have a very wasteful, highly inefficient, and pretty dangerous system of care here in the United States. And that goes for anyone in any context. So this isn't payer specific because unfortunately or potentially fortunately, we are all patients. We're all going to be patients one day. And so really, I think we have, as a country, concluded that we can do so much better than this. And so value is really a way of getting there. We're going to be talking about value-based care today, but I want to be clear about one thing. Value-based care is a means. It is not an end unto itself, right? So we're going to talk about some of the ways we measure how different countries are getting into value-based care, but I really want to make this point up at the top. Value-based care is not the end. It is a means to get there. What it is we're looking for are some of the things that I've listed here on this slide, right? Effectiveness and efficiency of our health system. That is incredibly important for any country. As many of you know, we are entering a demographic shift. Like many countries, we now have more older Americans than we have younger Americans coming into the system. This fundamentally is putting pressure on the sustainability of our healthcare system. And so not only do we have to be more efficient, but we also have to be more effective with the resources that we have. Lower cost, as I mentioned about sustainability, we simply cannot afford to spend at the levels that we are spending right now. I'll talk a little bit on the Medicaid side. Medicaid is usually the number one budget item in every state across the country. It's pushing on other areas of investment that we we could be making in our communities, whether it's education or housing or any other priority that we have. Simply put, if we don't rein in costs, we're going to crowd out every other type of investment that our country and our citizens so badly need. Patient-centered care. I think most of us have been a patient at some point in time, and we could probably argue that it wasn't the best moment of our lives, not just because we were in a medical emergency, but because the system today is not patient-centered. And what we know about systems that are not patient-centered is that they don't deliver great results. So we really need to put patients back at the center of care. I want to get back to this concept of better clinical outcomes, not just outcome measures such as life expectancy or avoidable deaths, but simply put, smaller measures, right? What are our outcomes for individuals who are living with diabetes? What are our outcomes for your chronic routine, COPD, heart failure? Again, when you look at these outcomes in the United States, we're simply not performing where we should be, right? Equitable health outcomes. This is something that's very important, I think, to everybody, no matter whether you live in rural America or urban America. We want people to have access to high quality health care. Provider flexibility. If you talk to a provider, whether that's a physician or a nurse, you probably know that we're in the middle of a provider burnout crisis. And one of the things that matters when it comes to burnout, I think people misunderstand this. Burnout isn't simply I have too much to do. Burnout is I'm feeling disconnected for the reason I even got into this profession in the first place. People don't train for 10, 20 years to become cogs in a machine. They want to be good providers. They want to be inspired in their work. And simply put, fee-for-service healthcare doesn't allow for that. We also really need higher levels of innovation. Unfortunately, we seem to be a little bit in a stagnant moment here in healthcare. We're having less and less levels of innovation than we would expect for an industry of its size and maturity. So what does this look like? Again, if you're newer to this movement, you may want some tangible examples. So I'm just going to go through two of the main business lines and talk to you a little bit about value in Medicare. Medicare Advantage, which is about 50% of the market today, this is sort of a baked-in value-based model. It's a capitated model, risk-adjusted for payments for the members that it serves, right? And then Medicare Advantage plans do downstream contracting with providers. We'll get back to Medicare Advantage and some of its advantages and value in just a second. Traditional Medicare, which sometimes we just call fee-for-service Medicare, that has a number of value-based offerings. As I mentioned, it's about half of the market. And this is really the area where CMS, the federal government, through its CMMI program, has the most amount of alternative payment models that are being offered, some of which you may have heard of. Others you're going to hear about today, maybe for the first time. But you may have heard of MSSP, the Medicare Shared Savings Program. This is a program that has been around for many years, and it has a large number of ACOs participating. To date, it's the largest and most comprehensive value-based offering for Medicare fee-for-service. You may have heard of ACO REACH, or in its previous incarnation, it was called direct contracting. This is a more aggressive approach. It's a 100% upside-downside model, which means it's a full risk model, again, for Medicare fee-for-service members. And a couple other models that you're going to hear about today, including Team and Ahead. And I won't go into the details on that because you've got great panels coming up that will get into that. So that's on the Medicare side of the house. But of course, the other large government payer is Medicaid. Medicaid is a state-federal partnership available in all 50 states, run by state agencies, but managed and regulated by the federal government. And what we see across the landscape in 50 states is every state is approaching this a little bit different, but I would say there's a lot of commonalities. You can look today, I've got the examples here of New York and Tennessee and Texas. So as you can probably tell, politically different states, but each of these has a value-based payment roadmap for the Medicaid program. And we'll talk a little bit more about what that looks like. So there's the overview. This is how we're doing it in lots of different business lines. But I think the question I probably get the most is, where are we on the journey to value? If you're a singular provider or a payer, it may be hard to see through the trees and look at the entire forest and answer the question, is this movement really on fire? Is it a slow-moving fire? Are we adding? Are we subtracting? Where are we on this? To answer that question, I always go back to the HCP LAN framework. That's the Healthcare Payment Learning and Action Network. This is a collaboration with CMS, where basically they do surveys of payers and different types of payers in the healthcare space to understand where are contracts headed, what types of contracts at what level of risk are payers and providers getting into. What you can see here on this chart is we start at low levels. So there's low levels of risk. Category 1, this would be your fee for service, right? So this is fee for service payment with no tie to quality, no tie to value. That's sort of the old historic system. And you'll start to see that orange color come up in the next couple slides. In category 2, we have fee for service that is linked to quality and value. So there is some sort of mechanism that ties the fee for service payment into quality. This could look like a quality incentive, a quality bump, things of that nature. No downside risk yet in category 2. In category 3, this is where we're looking at APMs, or alternative payment models, built very interestingly on the fee-for-service architecture. So this is still using the underlying fee-for-service system, but starting to really change the incentives. In category 3, we have what we call 3A and 3B. 3A is where you only have upside risk, and 3B, you start to take on downside risk. So that means the providers in those relationships are starting to have consequences for quality and budget overspend. Category 4 is the nirvana, where we're all trying to get population-based payment. This has always been the dream for value-based care and value-based care devotees, is that we would really shift away from a fee-for-service payment mechanism completely and get to this category 4. The reason I go over these is I want to show you where we are in terms of shifting away from value-based care. This is the 2024 data set, which reflects the survey that was conducted in 2023. 28.5% of U.S. healthcare payments today have now flow through downside risk contracts. So remember, that is looking at 3B and above. So we're not even looking at those who are starting, but we're starting to hit that 28.5% mark. Here's that data split up by lines of business. Again, this is the calendar 2023 year. This is the most recent layer of data that we have. Again, what you're going to see, categories 1 and 2, those are those gray pieces of these bar charts. Then you're going to have 3A, which is that light purple. And then you're going to look at 3B and 4, which is the dark purple and the green. What you can see is there's wide variability of adoption of value-based payment across lines of business. If I can leave you with nothing else today, it's this. People who look at that big headline number are not reading the data correctly. You need to understand how it's actually happening in the different lines of business to understand not just what the trends are, but also what is your role in this, depending on who you are. Are you a provider? Are you a payer? Are you a payvider? Who do you serve in your geography? That's where you need to get hyper-local about this data and these trend lines. This is another slightly complicated chart, but what I like to just sort of point out here is that this is segmented out by line of business, and don't pay too much attention between the 3B and the 4. What I really want you to look at is the trend over time. If anyone out there is still believing that value-based care is a passing fad, I posit to you that the data is telling us exactly the opposite. It is a slow and steady march towards value. You can probably tell there's been some shifts in some different areas. Check out that Medicare Advantage graph, right? Where category 4 risk-taking shifted a little bit in recent years. We'll talk about some reasons why. But ultimately, you are fooling yourself if you think we're ever going back to a system of fee-for-service health. The only thing that you're delaying is your own preparation to thrive in this new model of care. So again, this is how the categories split out for all lines of business. I wanted you to see all of this. I also wanted you to see that 92.7% of the market is represented in this survey, just so you know. This is a pretty accurate portrait of what's happening. What I really want to get into are the different lines of business. So let's start with commercial. Interestingly enough, what you will see, and this will be a topic of conversation on the panels, I am sure, is that 50% of the commercial spend is still in category 1, fee for service, no link to quality or value. We'll talk later about why that's a problem and where we think some movement can go to ratchet that up. Then what you see, about 10% in category 2, you see then 31% is in category 3. So we're getting towards that nirvana of being in category 4. And then there's 8% that is actually in population-based payment arrangements. So that's what the commercial landscape is looking at. Let's look at Medicare. So Medicare has a much smaller component. This is Medicare Advantage, much smaller component that is still in fee-for-service. What you can tell, though, is look at how big that green chunk is, right? So 34% of the dollars being flowed through Medicare Advantage is in a category 4. That's that level that we're aiming for. There's another 30% that's in category 3. You can tell very little still hanging out in category 2. So what are we seeing from this? This is a robust move in this market, much more advanced in value-based payment. Let's hit the other side. The other 50% of Medicare is in traditional Medicare payment models. What you see here, very similar. Even less of the traditional Medicare spend is in category 1, fee for service. You have a bulk, so that's that 41% that's in category 2, so some link to quality and value. And then you also see 30% is in category 3 and 11.9 or 12% is actually in category 4. So again, this is telling us really robust value-based model here in the traditional Medicare model. So let's now talk about Medicaid. Remember, this is the state-federal partnership at states. Interesting here, they're slightly lower, but still most of the Medicaid payments are in fee-for-service. Many states have not yet moved aggressively into value-based payment. That's a real spot of opportunity for those of you who are listening here today. We've got 9% in category 2, 34.4% in category 3, and only 9.2%. So again, we're looking at a Medicaid market globally that still has a lot of opportunity when it comes to value-based care. As an example, the partners at my firm, we were all part of a New York State Medicaid program when we worked with the federal government to move 80% of the Medicaid managed care spend into value-based payment models. We had a roadmap target that you see here. And the thing that I want to call out to you is not just that we hit the target, that's always a good thing to announce, but I want you to specifically look at how many more percentages we had in level 2 and in level 3, which is a capitated model. So these data are from 2020, which was the end of the demonstration period. The work has continued in New York State. These rates are a little bit higher today. But as you can see, 56% of the Medicaid spend is an upside downside. And then we even had 18% in those really high level population level payments. So, one state example, but I want to give you a sense of what the market is looking like. So, what has changed? Because here I've given you a little bit of the landscape of where we've been for the last few years. But if you haven't been living under a rock, you know that the last 12 months or so have been highly fluid, and it's having impacts in the healthcare space and specifically in the value space. So, I want to talk a little bit about what has changed. What is different today that maybe a year ago, I wouldn't have pointed these pieces out to you. The first is obviously we've had a federal government administration change. And with any federal administration change, priorities are different from the last. And some of the priorities have shifted. First and foremost, this is probably the question I get the most, is are we done with value? Absolutely not. Value-based care continues to be a bipartisan effort, which we are not seeing in any survey or polls that is losing any steam. Again, I just want to go back to my opening comments. The challenge of sustainability, quality, and outcomes, that's a bipartisan issue. That's not something that's going to change. So we still see value-based care being a top policy priority. However, some of the other directions are starting to change. You may remember that the last CMMI administration really talked heavily about having 100% of Medicare beneficiaries be in a valuable or accountable relationship by 2030. That conversation has changed. So we're moving away from every patient in an accountable relationship to really CMMI pushing the conversation about level of risk. They want to move faster up that corridor, right? So remember when I talked about the categories, they want to push the categories forward, push providers along that continuum, and have more of them in as the categories would be 3 and 4 level payments. So it's a different, I guess what I would say is it's a different take on the original question, but it is a really clear policy shift from this administration. One way we're seeing that is mandatory models being put out. Previous administrations were a little hesitant to be that forceful with providers and states and things of that nature. This administration does not have that. They are full blown. They are putting mandatory models out there. If you don't know what a mandatory model is, it basically means that if you find yourself on a list of where this model is going to be implemented, then you are on that list and you will be mandated to engage in that model, right? That's way different from saying, hey, we have a new APM. Those who want to be a part of it, please apply, right? So that's a huge power dynamic that has changed. What, again, we're seeing in this push into value, we're seeing mandates come down for more risk to be taken, and really importantly, sooner. Speed matters here. I've worked with ACOs that were in the very original ACO model, so I'm talking like 2010, 2011. They've had now 10 or more years to get it right, to build that infrastructure, to build that muscle memory, to build those clinical models. What we are seeing is that this federal administration is pushing for risk adoption faster. So while other providers had a good 10 years, if you are newer to this environment, you only maybe have a year or 2. Time matters in value-based payment, and I'm sure this is something that's going to come up in the panels later today. But what I always urge people is don't waste any time that you have. Use every minute at your disposition, because you can't get any more time back as we move to value. You can also see the recent physician fee schedule changes for Medicare were just finalized last week or 2 weeks ago. You can see, again, they're pushing towards less time in upside-only models. They have made some other changes, such as allowing smaller ACOs to participate in the program. I think those are 2 really interesting variables to be pushing on, allowing smaller ACOs or provider groups, and yet pushing them into risk contracts faster. Last but not least, there have been some tea leaves that some of you in the audience may have been able to read, but there is an ongoing conversation about how do we measure? And by that, I just mean, the dollars and cents are one thing, right? So how we set budgets, there's a lot of spirited debate in that side of the house, but I'm actually talking about the quality measures. I think there's a growing understanding that the quality measurement set that we have been used to in value-based payment and in fee-for-service, I should say, isn't necessarily translating to a value-based space. So let me just give you an example. In fee-for-service, where you get paid for how many services you do, potentially a breast cancer screening rate makes a lot of sense, right? How many individuals? Can you put them through the machine? Can you get them out the other side? Can you screen them for breast cancer? That's really a process measure. And I think what I would venture to say is we have been conflating process measures and outcome measures. As any ACO or ACO management group will tell you, that breast cancer screening rate has little or no impact in total quality and total cost of care. So maybe we need to move away from measuring process outcomes and really looking at clinical outcomes. There have been some hints from CMMI and the new team there around there may be interest in this, and I would just specifically call out the inclusion of PROMs, patient-reported outcome measures, as a place where we're starting to see this federal government shift. I will mention in Europe, in the value-based care movement, I would say they're far ahead of us on this. Many European nations institute PROMs, collect PROMs, and pay according to PROMs. So I think we have a really good base of evidence that we can look to and learn from on that side of the Atlantic. So I also just want to talk about some market forces that are shifting our two primary lines of business, which would be Medicare and Medicaid. And I say market forces, but I will just admit that much of what's happening in the market comes from federal government action. So let's talk about Medicare. Medicare spending has remained high. We're about a 3-year high right now, and all signs point to no end of this trend. And so this has really had an impact, and you'll hear from some actuaries on some of our panels today. This has definitely had an impact on projections on spending, projections against budgets, all of these kinds of things. I think there are lots of hot takes about why this is happening. Is it a post-pandemic spending bump? Is it just higher health needs? There are lots of questions swirling around about why we're seeing this, but there's a clear pattern, and we're not going to break that pattern anytime soon. CMS has also adjusted the Medicare risk adjustment rules of the road, and we don't have to have a whole panel discussion about the changes to RADV. The big headline here is that risk adjustment and the wild days of risk adjustment being your primary vehicle for finding savings or finding margin are over. And so providers are really taking this seriously. Plans are taking this seriously. And there's just been a really big shift on what I sort of call the revenue side of the house if you're working in Medicare. And the unicorns of Oak Street and Iora, you guys remember these guys? They were sold off pre-pandemic for a couple billion. And you saw really large companies, Amazon, Walgreens, Signify, scoop these folks up. And I think what we're starting to see is maybe those were flashes in the pan. Maybe the new co-model in Medicare doesn't actually work across a large-scaled population. And I think that leaves a lot of people asking the question, if that doesn't work, where are we headed next? You're also seeing really large insurers, folks who have historically led the pack, struggling in really new ways. And I bring you this little nugget just from an October earnings call from Optum. And Patrick Conway, who's been a leader in the value-based space for so long, he really attributed the losses here, I shouldn't say losses, they were flat, revenue in the last quarter to a couple different things. And I think what he said is tremendously interesting to sort of nitpick here. First of all, he mentions that the provider network grew too large in an unmanageable fashion. The reliance on affiliated and not aligned, and I want to be really clear about that language, and you're going to hear that a little bit later on some of the panels, physicians who are affiliated and not aligned to value-based models cost Optum money, right? So we'll dig into that a little bit later on some of the panels. Ultimately, Optum has a clinical value-based care model in its control. That's what it wants to put out into the field. And what Patrick is saying here is when we don't operate on that, when we don't execute on that, we don't see the revenue that we were anticipating. Ultimately, guys, whether this is on the revenue side of the house or on the expense side of the house, the interesting thing here is that value continues to be the answer. You can't manage your way through these challenges to the Medicare space any other way than doubling down on value-based payment. Let's talk about some of the shifts to Medicaid. So Medicaid celebrated its 60th birthday this year, and what we saw with that were some of the largest changes to the program that we've ever seen. Specifically, the changes in the One Big Beautiful Bill significantly impact this state-federal partnership model. The biggest and most impactful piece of this is the tightening up of Medicaid eligibility and generosity. There are a number of provisions, which I won't go into right here, that really make it harder for eligible Americans to access and retain their Medicaid coverage. The biggest thing here will be the re-enrollment periods that are set to start next year. The interesting and most sort of poignant thing to this is that you're going to end up, every single state is going to end up with a smaller population of individuals on Medicaid, but the risk level is going to go up, and it's going to go up significantly. And so since we're in a system where most states use managed care, Medicaid managed care, those health insurance companies are starting to figure out what is that going to look like. As an example, one of our clients who is in a full risk contract with a Medicaid managed care plan, they are starting to see significant losses in Medicaid members. So people simply exiting the plan, not re-enrolling already. For example, in this case, it was about 10% of their patient population. And so as you folks may know or will hear today, if you're in a value-based care arrangement and you lose 10% of your attributed population, that swings the arrangement in really interesting ways for both providers and payers. So we're entering a really new era. And by the way, I should say all of that is before the law even takes effect. So these are Medicaid members who are essentially self-selecting out of the program. So we can only imagine, and I would say I'm not sure anybody has a really good model for just how many Medicaid members we're going to lose that are going to come off the rolls here. So again, you're going to be left with a smaller Medicaid population, but they're going to be much sicker and a much more risky population. And there are a couple really great white papers, which I'm happy to link to for folks who want to take an actuarial deep dive into that. So here's the good news to all of those problems that I just put out. Value is the answer. Unfortunately, once again, going back to fee-for-service isn't the way forward. In fact, what I would posit is that value in Medicaid has worked only so-so, mostly because we've been looking at total cost of care general population arrangements. What I mean by that is they sort of shove one giant population into an overarching agreement. I think what this is going to push both Medicaid managed care companies and also provider groups to say is we need separate agreements for different subpopulations. And I think that is where we can have true innovation happen at that point of care. So that's sort of what's happened in the last 12 months or so. But I want to take a minute and just talk about where we're headed, because I do think there's a lot of anxiety. So I've shown you that value is on this trajectory to be the standard payment and clinical model. But are we sure of that? And where do we think we need to go next? The most simple way to talk about this is I've shown you the lines of business. I've shown you their adoption of value-based care. I want to show you this graph too, though, because it's really important. And this is how Americans access health insurance. So you can see that there's Medicare, there's Medicaid, there's uninsured, there's some military coverage, but you can see that the largest bucket here is commercial. 49% of Americans still receive their health insurance in a commercial environment. And so what I just want to say about that is that we are steadily approaching the tipping point of value in healthcare, in American U.S. healthcare. I think the question we always have to ask is, where is the tipping point? Where is the point where the market goes too far towards value-based care to ever look back? And we host an annual conference on value-based care every year. And we had our annual convening just a few weeks ago. And we had Rushika, who many of you may know as the founder and CEO of Iora. So he built one of the very first built for value models. And I asked him this very question. I said, what do you think the tipping point is? And I think Rushika and I agree is that we think it has to be about 40% of every provider's patient panel. So what I mean by that is until it becomes 40% of the patients who walk in the door who are in a value-based arrangement, we're still going to struggle to see the changes in the clinical approach to healthcare. And so as you can see in all of the documents and the charts that I showed you this morning, we're getting close. So 28, let's round up and call it 30. Maybe next year we get to 32. We're getting close. But ultimately, unlike the saying, right? Just like the saying always says, culture eats strategy for breakfast, we really need to make sure that we're monitoring this. And my belief is that commercial insurance, commercial value-based payment models have to push us over this 40%. Because as you saw on the previous graph, with half of Americans accessing health insurance through commercial, we're never going to get to that 40% of a patient panel if we don't crack the commercial space, I guess is what I would call it. My other thing that I would say is, I know oftentimes we talk about things bending before they break. I actually believe commercial is going to have to break before it bends. Today, the incentives simply aren't there for a number of reasons. And I know my colleagues and I are going to have a spirited debate about this on our next panel. But I actually believe that the cost hikes that we are seeing, the year-over-year cost increases in commercial, they will continue to the point where commercial insurance actually breaks and has to make a significant change and move out of fee-for-service and into value. And that is where I believe the tipping point will come from, because that will have a domino effect on every patient panel in America. Every provider in America will have to take this to the next level. So I think that is really going to be our tipping point. Let's talk about some of the things that are not working, where we need to make some more improvements. Primary care providers are the new attribution engine in a value-based world. We're going to have some great conversation on this next panel and later on in the day about should that be the case? What are some other options? What else could we be seeing? What I will say about this is not all primary care providers are ready for this huge shift in dynamics. We see a lot of investment on the state side and on the Medicare side to prepare people for this dynamic shift. But I would just say we still need to do more to make that happen. Lack of primary care and specialty care integration. This is a big one. I think we've been talking about this as a field for a long time. I think some of us are ready to get serious about it. Again, you'll hear about some of that on our panel. But simply put, flying blind on 70% or more of the spend is just not a strategy to have sustainable outcomes in value-based care. I'll talk to my health system colleagues a little bit for a second. We still continue to see hospitals or health systems bury their head in the sand a little bit on value-based care. There are definitely some innovative health systems and hospitals out there, but I would say the vast majority continue to use it as a defensive strategy, not as a growth strategy, not as something that they see they need to really be taking seriously in their delivery system model. Payers are also not always ready for this, and we have definitely started to see, as the pressures that I mentioned earlier start to really ramp up. Not all payers are created equal. Not all of them have invested in the capacities that they need to be front runners in this. There's a panel discussion later today on contracting, and we'll be getting into some of these little conversations a little bit later, but certainly payers are a little bit spread out across the board, and they're not all performing where they should be. And I would also just add, lastly, and I will say this administration, I think, is very aggressive on this last point, which is the data has to be there and the data has to improve for us to get to the next generation of value-based care. Who has access to data, how good that data is, and what the data is telling us. I've been saying this from since about 2010, but data is the new oil, right? And so if you are sitting on a data repository that is good and refined, you're in the money-making seat. If you don't have access to it, you're going to have a really hard time performing in value-based care. The last couple things that I will touch on, there's a lack of focus on certain parts of the delivery system. So certain things such as at-home and long-term care. I don't know if anybody saw recently, the Bureau of Labor Statistics just came out. I think it was on Tuesday. The number one projected job opening in the next 10 years is going to be home care. And so if we don't find a way, this is congruent with everything we know about the population and the aging of our communities. If we don't find a way to manage that spend of an aging population, especially at-home care can be incredibly valuable to these individuals, but it can be incredibly expensive. And so I definitely see the opportunity for value-based care models in long-term care as being an underexplored part of the delivery system. There are other subpopulations. I'd like to call out the intellectually and developmentally disabled. Those are populations that for a long time have been left behind, primarily because of the complexity of this population and the overlap between social services, things like integrated housing and things of that nature. And so they often are carved out of value-based care arrangements. They often have what I would kind of call multiple budgets in different places. So your state agency that deals with the disabled may have a budget for them. Your healthcare system has a budget for them. Other social services have budgets for them. They are definitely one of the more complex payment models for our population. But what we also know is that these are incredibly expensive populations when they are not managed well. And so we can either wait for some grand reordering of state agencies to become integrated, or I think we need to get really creative in the healthcare space and put some new models of care out there that are value-based, that do include housing, social care, healthcare. I think it's really time for that as well. Two other populations that I will briefly mention. One is the maternity episode. I've done work on this. I know lots of people have also done work on this. I will just say that maternity care in this country continues to be suboptimal, not just the outcomes, but the experience that women are facing every single day. We have not really gotten serious about what a value-based care model could look like. We've had some attempts both on the Medicaid side of the house and also some models coming out of CMMI. But ultimately, when you look at that evaluative research, you do not see the kinds of improvements that we need. Unfortunately, in this country, we don't invest a ton in maternity care just from a raw dollars and cents point of view. So this is partially why there's a lack of innovation. But I would argue if we're as concerned about the demographic shift as we say that we are, this is an area ripe for innovation, and we could do more to get this right. And lastly, I would also just say pediatrics, very same reasoning. Pediatrics tends to be high volume, low dollar. And so the opportunity to find shared savings isn't really as robust as in some other areas. But again, if we're moving to a model where we're becoming much more preventative in the care of our citizenry, I would argue that we got to do more to get pediatrics right. And there are some exciting models, but again, this is an area where we haven't seen as much performance in the value-based care space as we should. The next point, we certainly have a lack of systems thinking when it comes to how people access care. I will say this administration feels very aggressive on the topic of health technology, wearable technology. I think maybe this wasn't a conversation we were going to have 10 years ago, but most of us do wear watches and trackers and things like that. And there's definitely a great value proposition there for having patients provide more of the data themselves and moving away from a system that's completely based on claims data. I do think Amy Gleason at CMMI is obviously pushing a lot of this forward, and I think this is an area to watch. Hopefully in the next few years we can see some movement there, because I think simply waiting for people to show up at their primary care provider's door is a little bit of a lost cause. We're not going to get everybody in that way, and yet people are showing up every day in different places and points of care. I think the last couple things I'll just leave you with is this point I think is really important to me, is that thinking that the fee-for-service care model works in a value-based care world. And when I say care model, I actually mean what's happening inside of clinics and hospitals and doctors' offices all across America today. I think we've been very focused on payment reform, which is great. I was sharing with some colleagues just this morning that they were asking about my work in Europe, and I was saying, I think we're ahead of Europe by about 20, 25 years when it comes with payment redesign and reform. Obviously, a lot of that has to do with the creation of CMMI under the Affordable Health Care Act. However, where Europe and the rest of the world, the Middle East, Asia has us absolutely beat is the care redesign. And I think we have a lot to learn from our international colleagues about how they're redesigning systems of care to get better outcomes. Together, obviously, the triple aim is really what we've always been talking about, reducing the cost, which I think we have evidence our alternate payment models are doing a good job against. But I think we have a lot to learn from our European and Asian and Middle Eastern colleagues around how do we actually get better outcomes. And so I think this is a place where we have a lot of work to do as a field. Getting the finances right is a great base because that allows us to reinvest into some of these new care models. But I think we could certainly learn a lot more from them. And lastly, I just want to leave you with, I do sort of feel like there's a lack of imagination in this space sometimes. And I know it's been a while for some of us who have been in the value-based care movement. We can feel like day after day, we're arguing about different ways. How do we trend benchmarks? And that is all really important and good stuff. My concern a little bit is we're losing a little bit of the imagination, the what if, the possibilities of replacing a fee-for-service healthcare system with a value-based care system. And so I guess that is where I leave you today, is just to say, I think we all need to dream a lot bigger. We've gotten a lot right. We have a lot of evidence that this is going in the direction that we always wanted it to go. And I know sometimes it can feel like the changes and the pressures are immense, but I really want to push people to think bigger, think outside of our own healthcare systems. If you have the opportunity, connect with some international colleagues. Go see what's happening in Singapore. I promise you, it will absolutely blow your mind. Or go to a country like Estonia, where they actually have gotten to full interoperability, and just taking a peek at what doctors get to see about their patients every single day it will make your imagination run wild. And I think for us to continue to do the work that we are doing, it's not just about getting to value-based care 2.0. It's really about continuing to push the vision. And I think that's where all of us, whether you work in insurance, whether you work as a provider, whether you're a hospital CEO, we need to do better about thinking bigger and putting a bigger and bigger map up on the table in front of us, because I think that's how we're going to get to where we're going. So thank you for the opportunity to tell you a little bit about the state of value-based care. The panels that Nelson Mullins has lined up for you today are incredible. You're going to learn a lot. You're going to hear a lot of discussion. A lot of us know each other for many years. So I promise you, this is not the sanitized version of value-based care. These are practitioners in the field who are going to give you a really deep dive into what it looks like. So thank you so much for this opportunity, and I look forward to participating in some of these panels.